You may, oh, yes.
Okay.
And I think we can start, maybe.
Okay. So, good afternoon to people from Ukraine. My name is Shrikant Chinchalkar. I've conducted a few sessions. You probably already know me by now. So today's my today's presentation is on prevention and management of pitfalls in flexor tendon rehabilitation. We understand the anatomy of flexor tendons quite well, but it's very important for us to understand that the tendon orientation changes in different regions. For example, around the wrist joint, the tendons are kept in a compact position. So that means that your flexor pollicis longus, your flexor deterrum profundus, that is in the third layer, and flexor deterrum superficialis is compact when the tendons come out or are placed in a carpal canal. The tendons, upon emerging from the carpal channel, they diverge at a specific angle. And at A1 pulley, the tendons start to enter the fibro-osseous sheath. And at this level, the tendons have some convergence. We all know that the flexor deterrum profundus serves as an anchor to the lumbrical muscles, and the lumbrical muscles originate, and they are on the radial side. So the lumbrical muscles don't go through the fibro-osseous canal. However, they traverse obliquely as they are making their advancement towards the insertion in the lateral bands, and that is of the extensor system. And then at the level of proximal phalanx, the flexor deterrum superficialis splits into two slips, creating an opening for profundus tendon so that the profundus tendon can emerge out of that, and then, of course, advance towards the insertion at the distal phalanx, whereas flexor deterrum superficialis inserts on the middle phalanx. So if you look at the deep layer of the flexor system, that consists of flexor deterrum profundus and flexor pollicis longus. And then if you compare the middle layer of the flexor tendon, it is superficialis. So we can very well see that the index and small flexor deterrum superficialis is posterior to the long and ring finger superficialis, and that is at the level of the wrist. So here, of course, when you see that the flexor tendons have split into two splits, it creates an opening, and that opening is called as Camper's chiasma. And when you lift the tendons up, you see that the tendons receive blood supply, which are in a form of a venicular system, and they are labeled as venicular longum, that is long venicular or short venicular system. So if we pay closer attention to how these tendons or how much excursion do these tendons have, we can very well say that zone 1 has 5 millimeters of tendon excursion. And this is according to Verdin, who identified this back in 1960. And gradually over time, when the tendons come proximally, the excursion definitely increases significantly. So if we just take an example of flexor deterrum profundus, which has 5 millimeters of excursion at the distal phalanx, you can very well imagine then if we lose 1 millimeter of tendon excursion at the distal phalanx, and if the DIP joint happens to have 60 degrees of flexion, loss of 1 millimeter of tendon excursion will result into the loss of 12 degrees of angular motion at the distal phalanx. So anyway, it is important that we now look at how do we actually move our finger or flex our fingers from a fully extended position. When the fingers are fully extended, we can very well see that the oblique retinacular ligament, that purple stuff that you see, is maximally taut. When the finger is fully extended, your lateral band is dorsal to the anatomical axis of rotation at the PIP joint. At the metacarpophalangeal joint, your tendon is sitting right over, extensor tendon is sitting right over the metacarpal head, and you have a sagittal band. So you can very well see that everything is optimally taut when fingers are in full extension. You can then see that when we initiate motion from a free hand extension and when we initiate flexion of the fingers, we can see that the flexor deuterum superficialis initiates PIP joint motion first. So this is according to Raoul Tubiana from France, who identified that upon flexion of the PIP joint, the spiral oblique retinacular ligament relaxes, and subsequently it then allows the profundus to create a tension on the distal phalanx. And then as the profundus flexes the distal phalanx, with increased PIP and DIP joint flexion, you can very well imagine then that your oblique retinacular ligament is slack, as you see right here, and with increased flexion of the PIP and DIP joint, your lateral band, which is dorsal to the anatomical axis of rotation when the finger is fully straight, is now moving towards the volar side. So in other words, the lateral bands will start migrating volar to the joint axis at the PIP joint. And then gradually over time, as the PIP and DIP joint flexion increases, you can identify that your extensor digitorum communis, which is connected to the sagittal band at the metacarpophalangeal joint, with increased flexion of the PIP and DIP joint, your extensor digitorum communis slides more distally, and your sagittal band is moving away from the metacarpal head at the metacarpophalangeal joint. And as a result, it is causing the intraosseous structures, that is inserting on the intraosseous hood or extensor hood at the proximal phalanx. Then because of the pull on the intraosseous structure, as the tendons move proximally, then your metacarpophalangeal joint starts to flex gradually over time. And then this is how we complete the complete flexion of the whole entire, starting off with PIP joint, then to DIP joint, and then finally to the metacarpophalangeal joints over time. But it's important for us to understand that the vectors are continuously changing from fully extended position to fully flexed position, and that vector change is as a result of presence of your fibroosseous sheath, or you can very well say that the annular pulleys and cruciate pulleys that we have along the finger are primarily responsible for converting linear force into a rotatory torque, causing fingers to flex nicely. So now it's important for us to focus on few tendon protocols that have been published and well publicized. So we can say that most commonly used protocols, they were technically called as early motion program, but we're going to focus on these, whether they are truly an early motion program or is it allowing minimal motion of the tendon. So we know that Kleinert protocol consists of active extension, passive flexion. Durand protocol consists of just passive motion of the PIP and DIP joint in a tendon protected manner, whereas Washington regime initiated by Jimmy Chow, who used a combination of Kleinert and Durand. So if we pay attention to the Kleinert protocol as well as Washington regime, we can very well see that it is giving us passive flexion and active extension. And if you compare the motion that these passive flexion and active extension that we have, as a result of using Kleinert as well as Washington regime, there is no active flexion of the tendon or active activation of the flexor tendons in their protocols. So then the question arises that if there is no active flexion caused by gliding of the flexor tendon proximally, then whether the tendons buckle when the patients are passively pulled into flexion by means of rubber bands. And of course, you must have heard Dr. Don Lalonde saying that the passive flexion of the fingers only causes tendon buckling. And even though you may ask patient to perform active hold, that active hold causes the jerky motion of the tendon, which is likely to put quite a bit of stress at the repair side, maybe causing additional frictional forces as the tendon is attempting to move proximally with passive flexion, active hold, and the tendon is likely to rupture. So we can very well say that there is no proximal tendon excursion, especially of the flexor determ profundus and flexor determ superficialis, because there is no active flexion of the PIP and DIP joint. However, when the patients perform active extension against rubber band traction, we can very well see that the tendons only glide distally during extension or resisted extension these patients perform against the rubber band traction. So that means that when they are performing resisted extension, the tendons glide distally. However, the rubber bands pull the fingers abruptly in flexion. It causes an abrupt passive flexion of or passive buckling of the tendon at the PIP as well as DIP. So therefore, we can very well see that these were the primary causes for pitfalls whenever we used Kleinert, Duran, or Washington regime. Now, I have not focused much on Duran as yet. However, if you look at the Duran program, it basically consists of passive flexion and passive extension. We know that whenever we are performing passive flexion of the PIP joint and passive extension of the PIP joint, and at the same time, if you're doing passive flexion of the DIP and passive extension of the DIP joint, even though Duran mentioned that there is a 3 to 5 millimeters of tendon motion that occurs between FDS and FDP. But the question arises then, there is no active flexion. So therefore, all the principle that we talked about, that because there is no active flexion, when we perform passive flexion or passive extension, these tendons remain in a buckled position. And then there is no proximal tendon excursion. There is no tendon gliding distally even with this passive flexion, passive extension protocol. And this is probably the main reason there is a pitfall following the tendon repair. And then the tendons don't glide because there is no active motion whatsoever. So as we see that Duran mentioned in his paper that there is a 3 to 5 millimeters of tendon motion that prevents firm adhesion formation between the tendons in a fibrosis sheath. So then the question arises that if there is no active flexion, and if we are relying only on passive flexion, passive extension, or if we are relying only on passive flexion and active extension, is that amount of tendon gliding really enough for fingers or tendons to not have adhesion formation and yet produce greater amount of motion at the PIP as well as DIP joints, which is we haven't seen much of that. But if you look at the true active motion protocols, we can very well see that Strickland and Cannon, they allowed the patient to perform wrist tenodesis. That means wrist flexion, finger extension, wrist extension, finger flexion in a tenodesis manner, passive flexion and gentle hold. So that is still causing somewhat tendon gliding. But truly, if we pay attention to the true active motion protocol that was introduced by Dr. Small from Belfast, who performed controlled active motion of fingers following tendon repairs. However, Belfast regime didn't gain popularity back then because the failure rate or rupture rate was ranged from somewhere between 10 to 12%. And therefore, this Belfast regime did not gain popularity, especially in North America. However, they in Ireland, they kept on using the Belfast regime for longer periods of time. So Jinbo Tang recommended controlled active motion. And of course, that was further taken on by Dr. Don Lalonde and Higgins is his therapist, where they used wide awake procedure looking at the intraoperative active motion, which definitely has a better amount of gliding of the tendons, not only distally when the extension motion is performed, and also flexion when active motion is performed. That means that the tendon is moving back and forth, especially. However, before they perform active motion of the fingers, either in extension or in flexion, patients were recommended to do warm-up exercises using passive flexion to begin with, so that there is no resistance offered by the stiffness that has been created because of the swelling or because of the surgical procedure. In Manchester, they recommend using short splint, but the question again is debatable whether the short splint application is suitable for every individual who is having flexor tendon repairs and of course, going through the rehabilitation program. HULC stands for the place where I work. It's hand and upper limb center, Roth, McFarland, hand and upper limb center. We have looked at our method of management, which we have modified somewhat because of identifying patients' limited awareness of the percentage of motion. So anyway, I'll focus on that. So we can very well see that there is an active tendon motion in both the directions, towards flexion, towards extension as well. And by doing active motion in both the directions, the tendons have greater ability to glide proximally and tendons have a greater ability to glide distally. Now, I would like to bring to your attention that whenever we perform motion in extension, both these tendons glide distally because of extension of the PIP and DIP joint. But when we perform flexion of the PIP and DIP joint, based on the mechanism of digital flexion, as I discussed earlier, during flexion, your flexor digitorum superficialis truly is acting like an internal pulley to the flexor digitorum profundus, maximizing excursion, acting at the distal interphalangeal joint so that the distal interphalangeal joint flexes beautifully. So in other words, the active motion program definitely has a lot more advantages in terms of the tendon gliding distally, tendon gliding proximally, and having an adequate amount or appropriate or exact amount of differential tendon motion between FDS and FDP when we perform motion at the PIP as well as DIP joint. However, all these years, this is my 51st year of clinical practice, and I can very well see that I have been working towards achieving maximum surgery or striving towards improvisation of tendon surgery outcome. And I am contributed a bit based on the experiences that I have as well. But the other factors we need to consider from different point of view. Now let's look at which are these factors that will lead to pitfalls of the tendon rehabilitation. One, we know that not all injuries and wounds are the same. Some people have ragged injuries, some people have guillotine type. So we can very well see that the injury or the wound that these patients have following a transection of the tendon by whichever means that they have, then this will differ. For example, here, if the person is cutting an avocado with the hand or keeping the avocado in the hand and using a knife, then this is a guillotine type of an incision or transection of the tendon. So in this situation, the tendons will not retract as much, or the tendons will not probably retract at all. The tendons will be sitting right where they were transected. So in such situation, the repair is relatively much more easier. In comparison with this, if the person is using a knife and the hand slides on the blade of the knife, then we can very well see that the tendons, upon having tendon transection, the tendons will retract significantly proximally. So as a result, we know that the proximal retraction of the tendon is going to have an effect on, or maybe may cause the rupture of venicular system. So the tendons here are likely to be avascular following the tendon retraction as compared to the tendons in the first case right here. So there's different types of injury, and therefore, in order for a surgeon to repair these tendons, it's relatively much simpler because of the presence of the tendon in the same location as compared to the tendons which have retracted proximally. So the exposure required for the tendons to be brought in for repair is significantly much greater. So then the patient's age. We don't see patients of the same age group. We have patients who are older in their chronological age, or there are some patients who are younger. So secondly, if the older person is older person is likelihood of having some delayed healing, for example, due to some changes, geriatric changes that have occurred, as compared to a younger one. Younger one will have a better tendency to heal, or the tendency to heal faster in a younger age group as compared to older group. So that therefore patient's age is likelihood of being a part of pitfalls. And then some anatomical variations, which I'm going to discuss at a later stage. So the common anatomical variation that we are likely to see in the hand is deficient superficialis in the small finger. So in other words, if the small finger does not have profundus, if the small finger doesn't have superficialis, then the small finger is completely relying on flexor determinum profundus for extension. And if the tendon upon repair is scarred down at the site of repair, then it's quite likely that the patient may go on to having a lumbrical plus. The other anatomical variation that one would see in the hand is presence of flexor pollicis longus that is connected to the profundus of index and sometimes long and sometimes fourth and the fifth digit as well. So in that situation, of course, because of the anatomical variation, if the flexor tendons of index and long are repaired, however, if we have not instructed the patient not to use the thumb, it's quite likely if the person is performing resisted opposition to the dorsal blocking splint, it's quite likely that because of the pull on flexor pollicis longus, the flexor pollicis longus moving proximally may cause quite a bit of tension on the repair site on index and long tendons, and it's quite likely that these tendons are likely of rupture. Now, timing of repair. There is still a controversy, what is primary, what is delayed or late repairs and so on. And we can very well say that not exactly every individual who has a tendon transection is repaired in a form of a primary repair. It's quite likely that the patients may come to the clinic at a later stage after having realized that, oh, he can't move his fingers, so it's 5 to 7 days are gone. And remember, I talked about the stages of wound healing. We know that first 3 to 4 days are inflammatory phase. So quite likely that patient may not be coming to the hospital for tendon repair when they are an inflammatory phase. It's quite likely the patient may be having their tendons repaired in a delayed manner when they're in a fibroblastic period. So the timing of repair definitely will have an influence on the tendon excursion based on when the tendons were repaired. And then again, the surgeon skills, whether how they were taught in terms of handling the tendons and how the sutures are placed. But most important thing I can very well emphasize on that not every one of us heal exactly in a copybook style. For example, I'm from Asia, I'm from India, so I'm likelihood of producing keloids, I'm likelihood of producing massive scars. As compared to somebody from, say, from Africa, African decent people or African ethnic background people are likelihood of producing much more heavier scar than me as compared to a Caucasian. So healing process definitely differs in every individual. However, it is very difficult for us to identify who is a heavy or bad scar former and who is a normal scar former. So therefore, in these situations, it's quite likely that patients may have, because of the alteration or differences in healing process of their tendons, the likelihood of falling into those pitfalls that I talked about because of denser scar formation tendency that these patients have. The other being patient's compliance. Are all these patients that we see, are they really compliant? So compliance technically is dependent on the amount of information shared with the patient. We definitely need to emphasize on patient education so that patients must understand what are do's and don'ts. And Don Lalonde definitely mentions that when he is giving these patients some guidance as he's operating on these patients so that patients have a thorough understanding of their do's and don'ts. So even though patients have greater understanding of what is expected of them, the other factors will definitely contribute to the pitfalls factors, so to speak. And then therapy, patients, the therapist may have been brought into or educated in terms of different use of the protocols, and that may be one of the factors that will cause protocols or variations in the management. But most important thing is, what is the most important factor that is essential to prevent quite a bit of changes that we normally see is to post-op positioning of the wrist and hand following surgery. We still often see that the patients are coming to hand therapy with the big cast on keeping the wrist in flex position, PIPs and DIPs in fixed flex position. And these patients are often seen maybe 3 to 4 days post-operatively. So imagine if the patient have had surgery or injury a week ago, and then they had surgery today, and 3 days later, these patients are in hand therapy. You can very well understand that these patients are already in a dense fibroplasia period, and therefore these patients are likelihood of having firmer adhesion formation between the tendons as well as the fibroosseous sheath. And on top of that, patients are likelihood of having well-established flexion contractures of the PIP and DIP joint following surgical procedure and after these patients are seen in hand therapy. So I've given a general overview as to what pitfalls or what pitfalls factors that we should think about, and we want to maximize as much recovery of these patients as much possible so that they have greater amount of motion of their metacarpophalangeal joints, interphalangeal joints, and so on, so that they have a good function. So let's look at zone-specific flexor tendon pitfalls. So here, of course, the person had flexor deterrum profundus repair in zone 1. So the patient has reduced, or sometimes you will not have much of flexor deterrum profundus excursion. As I mentioned to you earlier, that FDP has maybe 5 millimeters of tendon excursion. And if the joint motion happens to be, say, 60 degrees, then 1 millimeter of tendon excursion gives you 12 degrees of range of motion or angular motion at the joint. But if you lose 1 millimeter or 2 millimeters of tendon excursion of profundus, then definitely you're going to have a limited flexion of the distal interphalangeal joint. And then if you look at if patients have a reduced gliding of flexor deterrum profundus, then it's very likely that the patients will have somewhere between 10 to 12% loss of grip strength. So it's one of my studies which you look into loss of grip strength, especially if there is a reduced gliding of the flexor deterrum profundus. The other factors being if the profundus is transected in zone 1, and if it has retracted, especially proximally, then the amount of exposure required is much greater. So in such situations, we can very well see that because of the proximal retraction and then the tendon repair, we can very well see that the patients are likelihood of having PIP and DIP joint flexion contracture, which then will lead to secondary metacarpophalangeal joint hyperextension. And this is the combined forces of the flexors and extensors that is causing small finger to ride in hyperextension. Keep in mind that the small finger at the metacarpophalangeal joint has a greater dorsal curvature, and therefore the small finger has greater amount of dorsal curvature dorsally, and as a result of tendon adhesion and PIP joint flexion contracture, the metacarpophalangeal joint will always ride in hyperextension, and that will compound to the greater flexion deformity at the proximal interphalangeal joint as well as distal interphalangeal joint. So therefore, I have made a note here that small fingers are very notorious for forming many deformities such as flexion contractures, and especially if the person has a deficient superficialis and profundus is cut and profundus is now stuck to the fibrous sheath, then they're going to have a lumbrical plus phenomena, or in addition to that, they'll have changes that are occurring at the metacarpophalangeal joint. For example, here, the person's metacarpophalangeal joint is riding in much greater hyperextension. So you can very well imagine that the sagittal band at the metacarpophalangeal joints have become somewhat attenuated, and therefore they are not limiting excessive amount of excursion of the extensor deterrum communis, as well as the extensor digiti minimi as well. So there was one paper written by an individual from Florida who mentioned that rehabilitation techniques for applying immediate active tension in zone 1 and 2 flexor tendon repair. So this was the therapist's recommendation who wrote that article. The DIP joint must be splinted at about 40 to 45 degrees in flexion for 3 weeks while the patient's hand is in a dorsal blocking splint. And then the therapist's recommendation was that the patient perform relaxed composite flexion to allow active tension. So her analogy was that by performing this amount of motion, there is approximately 3 millimeters of tendon excursion in zone 1, which was calculated that range 45 to 75 degrees of flexion of the distal phalanx gives 3 millimeters of tendon motion. However, this is not the type of management a person should have following zone 1 tendon injury. So if we look at the other complications associated with zone 1, tendon rupture may be one of the common ones, depending on the activity that the person is performing. However, if the patient is cautious enough in not overusing his hand, then it's quite likely, if he's not focusing on maintaining the DIP joint flexion, we have seen that patients with the management that was previously described by an author that has led to DIP joint flexion contracture. So if a person has a DIP joint flexion contracture, that will always result into a secondary swan neck deformity. So this is a patient who had DIP joint flexion contracture as a result of zone 1 tendon repair. His PIP joint is riding in hyperextension. He was offered a corrective surgery. However, patient wanted to think about it. And then, of course, 2 months later, he came back and then he had this kind of a snapping swan neck deformity. And that was secondary to the DIP joint flexion contracture. We performed cadaver dissection to identify as to what would happen if the person has a DIP joint flexion contracture. So you can very well imagine that if a person has a well-established DIP joint flexion contracture, then your lateral bands will ride dorsally and they will become a tension band on the dorsal of the PIP joint, limiting active flexion of the PIP joint. So as a result, patients will have an established DIP joint flexion contracture, but on top of that, because of the translation of the lateral bands dorsal to the anatomical axis of rotation at PIP joint, the volar plate will become lax over time, and now the person has volar plate laxity. In addition to that, the person has a secondary swan neck deformity. So DIP joint flexion contracture is difficult to correct because of the poor leverage system. So in order for us to be proactive, we must prevent the flexion or contracture formation is very critical. My recommendation is never ever keep the DIP joint in flexion. And patients should be given a static splint, corrective splint. However, many a times patients are fitted with the silver ring splint for swan neck deformity, but in this situation, the ring splints are not beneficial because of the dynamic swan neck, which is as a result of DIP joint flexion contract. So to prevent progressive deformity, PIP joint should be held in flexion, as you see in this splint, and then gradually extending the DIP joint in a serial manner towards extension so that you can maximize DIP joint extension over time, and then it's quite likely that you may have to induce volar plate tightness at the PIP. From the therapeutic intervention point of view, this is a patient who had a lack of DIP joint flexion, but you will see that these patients often will show hyperflexion tendency at the metacarpophalangeal joint. So in order to maximize excursion of the flexor deterrum profundus, we must provide these patients by blocking MCP joint in extension and PIP joint in extension splint and encouraging patient to perform active flexion as you see right here. And that should increase active flexion. And in addition to that, you may provide him with the splint that blocks the PIP joint in neutral, and then you can encourage person to perform resisted flexion and extension when the PIP joint is blocked. Or in addition to that, you may consider providing the patient with the full MP joint extension splint, blocking the PIP joint in neutral, and then allowing the person to flex the DIP joint. Patient can also perform resisted flexion as you see right here. And then, of course, that will gradually increase excursion as you can see right here. So you can imagine that there is a very minimal excursion of flexor deterrens profundus. And many times it becomes very difficult for the patient to have or achieve maximum excursion of flexor deterrens profundus, but this can be instituted at a later stage. However, we have modified the treatment to prevent this from happening, in which I'm going to focus at a certain point. So in addition to the management through splinting, resisted flexion, we may use ultrasound treatment for these individuals and may use electrical stimulation to maximize excursion of flexor deterrens profundus over time. And then this is a patient who neglected his finger for additional 2 months, who ended up having DIP joint flexion contracture, having painful swan neck deformity at the PIP joint. Of course, these patients required a release and then K-wire fixation, and then we started moving the PIP joint from active gliding point of view. So surgical correction and early PIP joint motion following release of the DIP joint flexion contracture is recommended especially. Now let's look at zone 2 injury. Tendon ruptures are now becoming less common because of our understanding of tendon biomechanics. However, there are still some patients who, if they are non-compliant, then they have had the tendon rupture. But most common being patients having flexion contractures or having reduced excursion of flexor deterrens profundus or flexor deterrens superficialis, or lumbrical plus. We'll look at all these complications, zone 2 complications in detail. So tendon adhesions are more common, ruptures are less common. However, PIP joint flexion contractures are very common and they must be avoided right from the beginning. But if they have reduced gliding amplitude of the flexor tendon, then you'll see that the patients will have hyperflexion of the metacarpophalangeal joint, as you see right here. The video should work, but anyway, it may take a bit of a moment. So here the patient has hyperflexion at the metacarpophalangeal joint. And of course, this patient has hyperextension of the metacarpophalangeal joint because of PIP joint flexion contraction. Or you are likely of having quadriga effect. We'll look at those and how to manage these complications, especially in zone 2. Or patients are likely of having paradoxical extension of the PIP joint, especially when they have a rupture of the flexor deterrens profundus tendon. So zone 2, the most common being patients having reduced PIP and DIP joint flexion because there is a limited differential tendon excursion between FDS and FDP. Or patients may have a lumbrical plus. This is a classic test for lumbrical plus. We often perform passive flexion and ask a person to hold that flexion posture. And if the tendon abruptly comes in extension, is definitely suggestive of lumbrical plus. So this is a person having deficient superficialis. And in this situation, you can imagine that the small finger relies on profundus for complete flexion. So if the tendon is stuck, the profundus is stuck at the site where it is repaired, then patients are likely of having lumbrical plus phenomenon. So let's keep in mind that lumbrical plus is profound in small finger, especially when the finger has deficient superficiality. Because the small finger is dependent on flexor deterrens profundus excursion, and therefore all small fingers should be treated by means of early flexor tendon gliding exercises following tendon repair. So as I mentioned to you that the flexion contractures are relatively quite common. This is a patient who has multiple flexor tendon repairs. So he was in a dorsal blocking splint, and we know that if you have a massive swelling and positioning of the fingers is such that the joints are kept in flex position, they're bound to form flexion contracts. So we treated these patients by using ultrasound treatment. We use electrical stimulation on the extensor side, and then later on, when appropriate, lead time, we encourage patient to perform electrical stimulation on flexor side. However, we had to still fight with the stiffness in his hand. So in this situation, in order for us to maintain gains we made through therapy, we maintain these gains by using CPM, and we use elastomer inserts for scar management. So we changed the splint. We gradually started bringing the PIP joint in extension by using serial extension splinting over time, use ultrasound treatment, and then this is the person's results finally. Of course, this was quite challenging. We had to get focus on all the therapeutic modalities and then strengthening and so on until the patient has a reasonably good range of motion. So how should we treat the MCP joint hyperextension if these patients have because of the PIP joint flexion contracts? So it's important that we block the metacarpophalangeal joint in flexion. By doing so, we are causing tendon acceleration on the dorsal side. So this is MCP joint hyperextension with PIP joint flexion contracture. This is a tendon acceleration with MCP joint block. And of course, with the splint, we encourage the person to perform resistant extension. And of course, we use DIP joint blocking exercises to maximize excursion of the tendon. So these are the way we can maximize mobility of the tendon and then minimize them to have any contracture formation over time. So in addition to all these techniques that I have presented here, it's important that the patient should be treated by means of a passive PIP joint extension exercises as you're focusing on flexion as well. And at night, in order to prevent the finger from sitting in flex position, we need to provide these patients with nighttime PIP joint extension splint as well. So quadriga is one of the common problem, and we see that when person has a reduced gliding amplitude of the tendons, you can see that it will cause or have an effect on gliding of the flexor tendons on the adjacent side. So here, of course, one of our cadaver dissection I conducted in the lab. So we have found out that flexor deuterum profundus is basically the ulnar three fingers are connected by the flexor deuterum profundus. They have some interconnection between these profundi. And then if we limit the gliding amplitude of one of the tendons, as we're demonstrating right here, we can see that because of the limited gliding amplitude of one of the fingers, the other fingers have difficulty flexing as well. So therefore, it is important for us to block the metacarpophalangeal joint and maximize the mobility of the PIP and DIP. So syndrome of quadriga that was first identified by Verdun back in 1960, it's only a page-and-a-half article. So Verdun identified that muscular body of the flexor tendons can affect efficiently if the gliding amplitude of each and every tendon is normal. And especially if one tendon loses its excursion in one of the fingers, then adjacent fingers also have a reduced excursion. So having noticed this, having read this article and having identified the symptom that we came across, we identified that the ring finger produces the greatest detriment with an up to 47% of reduction in total active range of motion. So this is one of our paper, the effect of isolated finger stiffness on adjacent ring fingers. We identified that the ring finger is the most notorious one to produce severe quadriga effect. The next finger is the long finger, which has a tendency to produce greater quadriga effect. So how do we treat these patients? Because we often will see that these patients have hyperflexion tendency of the metacarpophalangeal joint. So as you see right here. So if the person has a hyperflexion tendency, then we must identify at what angle of the MCP joint the person has a greater excursion of the PIP and DIP joint. And based on that, we provide these patients with an MP block so that we maximize excursion of the PIP and DIP joint. And by treating the same patient is showing reasonably good results here. As you can see, he has full range of motion of his small finger and reduction of quadriga effect as well. So how do we treat lumbrical plus if the person has presence of this? It is important that we triple buddy tape the fingers, as you see right here, and encourage deactivation of the lumbrical, especially when all the fingers are loose. So my preference is to use the buddy tapes, triple buddy tapes to index, long, and ring at the distal phalanx, and then another triple buddy tape I would use at the middle phalanx and encourage patient to perform active flexion of the PIP and DIP joint. And of course, these patients also require ultrasound treatment and then using electrical stimulation to maximize excursion of flexor determinum profundus and flexor determinum superficialis. So now let's focus in details on zone 2 anatomy. So if you look at the zone 2 anatomy, it changes its orientation. So proximally, when the tendons are proximal to the PIP joint, we can see that flexor determinum superficialis is superficial to profundus. Just around the PIP joint in the middle section, flexor determinum superficialis splits into two lateral slips. So here, flexor determinum superficialis is lateral to profundus, right in the center. And distally, superficialis then becomes posterior to profundus. So in other words, in zone 2, the orientation of superficialis in relation to profundus definitely changes. So we divided experimentally on our lab the location where the superficialis is different in relation to profundus. And we carried out some cadaveric study to identify what exactly will happen if we lose normal excursion of the tendon. So here, of course, by pulling on the tendon, there is no restriction of any kind. The finger beautifully comes down to the palm without having any resistance. Here we suture the tendons, superficialis and profundus, to each other and simulating tendon adhesion between these two tendons. And when we pulled on the tendon, we identified that neither PIP joint nor DIP joint has full motion. Here, of course, DIP joint has no motion whatsoever, but PIP joint has reduced motion as compared to the motion right here. So based on that, we carried out some cadaveric work to see what would happen and how we can maximize excursion of flexor determinum profundus and flexor determinum superficialis together after the tendons were repaired. So here we sutured the tendons, especially in zone 2C, when the superficialis is superficial to profundus. And of course, when we pulled on the tendon, we identified that PIP joint had reduced range of motion and DIP joint had very minimal range of motion actively. So based on this, we identified that if the tendon adhesion is proximally placed, if the minimal motion is occurring between FDS and FDP during flexion exercises, and if the tendons form adhesions proximally, then patients will have loss of PIP joint and loss of DIP joint motion. And if the tendons are tethered somewhat distally in the middle section 2B zone, then patients will have a greater PIP joint motion, whereas patients will have a lesser DIP joint flexion, as you see on this cadaveric model. And then if the tendons are sutured distally at the insertion site, so when you pull on the tendon, it didn't offer as much resistance to motion of the PIP and DIP joint. So PIP flexed well, DIP joint flexed well as well. So based on that, we needed to modify our treatment programs. What we did is looked at the literature review and saw what exactly is done by various authors. So we came across many papers, and here, of course, this is the classic paper written by Wu and Tang, which showed that physiological reasoning for early control mobilization helps in increasing tendon vascularity with mobilization. It helps in stimulation of tenocytes maturation process and helps in remodeling the tendons. And of course, it gives us a better tensile strength of the tendon because of the early active motion that we're being performed. And we have a better excursion properties and superior result. So here the person has a tendon repair. And of course, we initially, in the first week, will allow the person to perform slight flexion of the fingers. And then gradually over time, as the patient progressed during their inflammatory phase to fibroplasia phase to remodeling phase, we kept on increasing arc of motion gradually over time. And by increasing the arc of motion gradually over time, we identified that the patients had greater arc of motion at the PIP and DIP joint, and therefore they have a better excursion properties. And then we modified our treatment program by encouraging patients to perform active flexion to the limits of finger distance. Because we are identified that the patients had difficulty understanding what exactly is 50% arc of motion. So we didn't want these patients to be overzealous in performing or thinking that this is 50% motion, because we can very well say that the amount of flexion performed at a joint by the tendons is directly proportional to the load and resistance placed on the excursion of the tendon or at the repair site. So we want to minimize any active load or active tension at the repair site by allowing these patients to only perform flexion to a linear distance. So here it's a small finger. So we told the patient to perform flexion to 2 finger distance in this week. So let's go back here just 1 second. So initially we encourage patient to perform flexion, active flexion to 2 finger distance, emphasizing that they are extending the PIP joint completely while the wrist being in neutral. They're working on active extension of the distal phalanx while they're performing an extension, yet they're performing active flexion to 2 finger distance. And then the person carried out with flexion to 2 finger distance the second week, and then 1 finger distance the third week, and then finally to the distal palmar crease on the fourth week. So this is the patient's active flexion. But however, we must understand that we are not allowing these patients to perform active flexion outrightly anytime, even if they are performing 5 to 6 times, exercising 15 to 20 repetitions 5 to 6 times per day. So we told them that before they actually perform active range of motion, they must perform passive flexion of the fingers, whatever distance they can go, and then active extension, passive flexion, and active extension before they actually attempt active flexion to the distance of 2 finger distance. But what if the person has ring, long, or index? We recommended these patients that they perform active flexion to 3 finger distance held vertically, and then they perform flexion to 3 finger distance the first week, then 2 finger distance the second week, 1 finger distance the third week, and complete flexion to the distal palmar crease in the fourth week. And then we also emphasize, based on Amadio's work, that patients must perform wrist flexion, finger extension, wrist extension, finger flexion, and assisting the fingers in flexion, not place and hold, but flexing the fingers as the fingers go in a tenodesis position. So this is the same patient who is showing range of motion at about 12 weeks post-operatively, and then gradually you'll see that the scar tissue will continuously remodel over time, giving us a perfect range of motion at the PIP and DIP joint. So currently there are many changes that will be occurring in Zone 2 management. So we can very well understand Dr. Don Lalonde's take on flexor tendon rehabilitation. Especially they consider flexing the fingers to only 50%, but we decided to use that in a linear direction. And then of course, Manchester short splint. There are some benefits of that. And then of course, there is another paper which just emerged not too long ago, which is looking at range of motion progression during healing on a no splint, no tenodesis, protection, immediate full composite extension regimes. So now let's look at Zone 3 complication. We know that the Zone 3 is the largest area. If we pay attention to the Zone 3, it's from the distal edge of carpal tunnel to A1 pulley, as you can see right here. It's a larger area. Anatomy of the flexor tendon changes. Anatomy of the flexor tendon changes in Zone 3. Proximally, the tendons are in a close, compact position. They're next to each other. That means that the index finger flexor datum profundus and superficialis sitting adjacent to the long finger tendons, and then long finger tendon is adjacent to ring and so on, and then ring is adjacent to the small finger. Whereas distally, before the flexor datum profundus and superficialis enter the A1 pulley, we know that the profundus serves as an anchor to the lumbrical muscles. So lumbrical muscles traverses across obliquely as it is advancing towards its insertion, and it's radially placed. So it's very important for us to understand Zone 3 anatomy in detail for us to understand that it's quite likely that Zone 3 distal complications will be different as compared to Zone 3 proximal complications. So these are some of our cases where we identified that patients had PIP joint flexion contracture. So Zone 3 distal showed flexion contracture secondary to scarring between the lumbrical and intertendinous adhesions, that is between FDS and MDP. And this is proximal to, of course, the opening of the fibrosis sheath. And then when we did the cadaveric simulation of the complications that we encountered with some of our patients, we identified that if there is a scarring or adhesion between the lumbrical and the tendons proximal to the fibrosis sheath, the tendon gliding was somewhat difficult. And of course, we carried out this experimentation to thoroughly understand the complication that we identified in our clinical situation. And then back then when we were using this technique, of course, we were using the Kleinert technique, but now we have reverted back. We have gone back to using the active motion program. However, we have to ensure that positioning of the metacarpophalangeal joint in a dorsal blocking splint is not as much in flexion, and gradually over time, we must increase the position of the MCP joint by 10 degrees on a weekly basis in order to prevent any firm adhesion formation between the lumbrical and your flexor tendons, which are entering into the fibrosis. So this is a patient where we adjusted the splint, and then of course, we can see the results of these patients who have full extension as well as full flexion of the finger. So we made contribution by saying that to prevent tendon and lumbrical adhesion proximal to A1 pulley, it's important that we adjust the MCP position on a weekly basis to have complete excursion of the tendon.
And back. Okay.
So we see that because the tendons are in a close proximity with each other, the tendon adhesions at the level of the wrist in Zone 3 proximal is likelihood of leading to the limitation in extension of one finger at a time. So in other words, if the tendons are scarred down just distal to the carpal canal, if the tendons are tethered, so say for example, these tendons now have become one tendon, so patients will have difficulty performing one finger extension at a time. So these fingers will become one finger, so they can open the fingers completely and close the fingers completely. However, they'll have loss of motion of one finger at a time. So this is what we identified in our cadaver model by simulating tendon adhesion between ring and long. When we pulled on the tendon, we identified that ring and long had become one finger and the fingers flexed at the same time. However, when we were holding on to the long finger flexor tendon in flexion, we identified that we could not extend the ring finger at all. So we modified the treatment by allowing these patients to perform one finger extension at a time, one finger flexion at a time, and then gradually allowing the tendons of the index finger moving away or separately from the long finger tendons moving separately away from the ring finger, and so on, so that we could maximize their arc of motion. So complication in zone proximal to zone 3 and 4. We know that zone 3 and 4, we know that if the tendons are scarred down to each other and proximal, depending on the level of these adhesions, patients are likely of having decreased composite wrist and digital flexion or extension. In addition to that, they'll have a reduced flexor tendon excursion. They'll have a limited or no independent finger extension or flexion. And of course, patients will have limited motion between the tendons. So we came across some of our failed cases following tendon repair. We identified that the patient who had full house or spaghetti wrist, the tendons were cut right there. So after repairing of the tendon, patient had limited independent motion of FDS and FDP. Patient also ended up having flexion contracture of the wrist, as well as having limited extension of the metacarpophalangeal joint as well as interphalangeal joint. So in order to maximize mobility, we had to, in these situations, we had to use electrical stimulation by placing the wrist in a variable flexion and then bringing the wrist to variable in extension position. And of course, by using electrical stim on the extensor side, we could increase the strength of extensors so that extensors could glide against the possible tension on the flexor side. And then of course, we use electrical stimulation for flexors by keeping the wrist in extension. And this is the patient who has multiple tendons transected repairs. We could maximize their excursion of the tendon. However, having looked at some of our failures requiring lengthier rehabilitation program following this management, we are focusing on how we can prevent this from happening in our future cases. So often patients will have a long flexor tendon tightness. We had to provide these patients with the dynamic or static progressive extension splinting. And we know that the extensors are 4 to 6 times weaker than flexors. And especially if we have limited excursion of the extensor tendon because of the flexion contractures on the volar side, if we do not build the strength of extensors, then we may not be able to sustain or retain the improvement that we achieved. So therefore, we had to use electrical stimulation for extensor system. So these patients require ultrasound treatment, electrical stimulation, management of the scar. However, we now focus on preventing these that we saw earlier, that if the patients have multiple flexor tendon repairs right here, we encourage patients to perform one finger extension at a time, as you see right here, and one finger flexion at a time. So here is the patient who had multiple tendon transection, and then he also had a distal radial nerve fracture. We are encouraging him to perform one finger extension in a controlled manner so that we can glide these tendons away from each other so that they have freedom of motion so that they can move one finger extension and one finger flexion at a time. So results are very fascinating, and I'll show you another case who had massive limitation. So this is the patient whom we thought had done remarkably well. He's a nephrology resident at our hospital. He had multiple tendons cut. And then, of course, we allowed him to move the fingers in a controlled manner, his full extension, full flexion. But when we looked at his independent motion of FDS and FDP, we identified that there was no physical excursion of FDS in relation to FDP. And the patient was dissatisfied as well, because he came back after we had discharged him. He came back within a week's period of time. He said, I'm not very happy with my hand because I could not perform a rectal exam on a patient. So especially we went to the drawing board, and then we decided to treat these patients somewhat differently. So modification of therapy in such situation, this is again another spaghetti wrist. So we carried out the one finger extension and flexion, as I mentioned to you earlier. And of course, this patient is showing great independent excursion of the tendon. So this is my editing problem, but anyway. So here, of course, same patient whom we treated with the modification of the treatment program. He could move his fingers very well independently. So we prevented those complications that we have encountered previously with few of our cases. So here is the patient multiple tendons transection. And then with the modification of the treatment program, he can extend one finger at a time. And then, of course, has complete freedom of motion of each and every finger. Now let's look at Fpl complications. So we know that the Fpl excursion is quite significant.
A little bit of CMC.
So here, of course, when you pull on the Fpl, it must glide at the proximal phalanx as well as around the trapezium, metacarpal joint, and so on. So Fpl complications are similar to what I've already presented. Fpl contractures or adhesions are quite likely to happen. Fpl ruptures are relatively less common now because of our understanding of Fpl biomechanics. However, if we have not restored Fpl gliding, then of course the hyperactivity of flexor pollicis brevis may limit gliding of flexor pollicis longus excursion. IP joint contractures or adduction contractures are quite common. Reduced grip strength, pin strength, reduced tensile function, and the patients are likelihood of having reverse Lindbergh sign. So we have seen that IP joint flexion contracture of the thumb leads to secondary swan neck deformity. So this is something that we need to prevent at any cost right from the beginning. Because if the person has a secondary swan neck deformity secondary to IP joint flexion contracture, then that will increase a load on the CMC joint, and prematurely the individual or patient will end up having premature CMC joint arthrosis. So this is a patient who has a hyperflexion of the MP joint, and this particular video will show limited gliding of FPL. So in order for us to manage these type of situations, it's important that we block the Mpa and Cmc joint, and by blocking the Mcp and Cmc joint, we can then encourage patient to perform FPL gliding. So you must provide them with the splint that position the CMC as well as MP joint in a variable position. You can gradually adjust the position of CMC and MP joint and then maximize the mobility of IP joint. However, this is preventable, so we must keep in mind that we are preventing this from happening right from the beginning. And this patient shows reverse Lindbergh. Lindbergh is interconnection between FPL and profundus of index long, and sometimes ring and small as well. So this was quite debilitating for the patient. Whenever he performed grip, he abnormally noted that his IP joint was flexing. So looking at or doing his examination, we had to provide these patients with the CMC splint, block the FPL excursion, just work on profundus gliding, and then with the management, of course, the person has a greater amount of flexion of the fingers without having much of an interference at the interphalangeal joint, as you see right here. So in conclusion, flexor tendon rehabilitation is now becoming less challenging with the advances in the surgical and therapeutic management. We can very well say that understanding of tendon biomechanics, suturing techniques, and tendon healing definitely has suggested us improvisation of therapy procedures following tendon repairs or tendon reconstruction. And therefore, it is important that we as clinicians understand these complications so that we can minimize those right from the beginning. And if they're starting to form as the patients are progressing their healing phases, then we can prevent them so that the patients have better excursion of the tendons and better hand function. Thank you.
So thank you very much, Shrikant, for a wonderful lecture.
Thank you.
Great talk.
Are there any questions?
There is a question. One of our colleague asked you, can you please spend more time and explain about quadriga effect?
Okay, yeah, sure. So quadriga could be on the extensor side, or quadriga could be on the flexor side. So looking at the quadriga on the flexor side, Verdun identified that small ring and long finger, the muscle fibers are somewhat interconnected, or they're connected to each other. So if you have lost excursion of one of the flexor tendons in one finger, you have lost excursion of the flexor tendons on the adjacent finger. So as a result, because if you lose excursion of one finger, and if you have lost excursion of flexor tendons on the adjacent side, your hand strength is much lesser. So, and this is something which can be seen, especially when patients have tendon adhesions in one of the finger, either caused by the tendon repair, and the tendons have scarred down in a fibrosis sheet, or it could be caused by the fracture or fracture dislocation of the fingers, where the joints are stiffer, and therefore, because of the joint stiffness, the excursion of the tendon is lost. So in such situation, then you have difficulty making a fist, difficulty using the hand, you don't have good power grip, you don't have good manipulative skills, and so on. So therefore, in order to prevent any quadriga effect, it is important that we not only focus on the excursion of involved finger per se, but also we look at the excursion of the adjacent tendons as well. For example, we know that if we do a superficial stress in a small finger, for example, we know that there is a deficient superficialis, right? So if we let go the ring finger, then there is a greater motion of the PIP joint. If we let go the long finger, then we even have a greater flexion of all the fingers. So many a times we do not pay attention to the excursion of the adjacent digits. So say, for example, if the ring finger is dislocated, and now the ring finger is, if the PIP joint is dislocated, you have reduced the PIP joint now, but your ring finger is stiffer. And if your ring finger is stiffer, this ring finger, stiffness of ring finger is going to affect the small finger profundus excursion, and therefore it will produce quadriga effect as a result of stiff ring finger. So therefore, by allowing this ring finger to have maximum amount of excursion over time, you're going to have a better excursion of flexor determ profundus on the small finger. So that's the quadriga effect on the flexor side. Maybe we can do a session on quadriga. I have whole 1.5 hour talk on quadriga, syndrome of quadriga dividing into flexor, dividing into extensor, where I go into a lot more details on quadriga effect.
So that would be great. And about using the artificial quadriga for rehabilitation.
Right. And if suppose you have a loss of excursion of one of the extensor tendons, extensor deuterum communis in one finger, your likelihood of having loss of excursion of extensor deuterum communis on the adjacent fingers. For example, if suppose somebody has a sagittal band rupture in one finger. So when you lose sagittal band stability at the metacarpophalangeal joint, you are unable to extend the involved finger. So as a result, the adjacent fingers also lose excursion. So now you have a quadriga, extensor quadriga. But because your fingers have lost extension of the metacarpophalangeal joint, you have an adaptive shortening of your intraosseous muscle, and extensor quadriga will always result into a secondary swan neck deformity. Yeah, so there are many causes for extensor quadriga as well.
Oh, thank you very much. I have a Limburg on my.
You have a Limburg sign, yeah.
So that's about the Limburg effect. I can work with this, so it's
yeah.
But sometimes it's interesting about this. Me and my colleague also thinks about the dominant hand and the role of the Limburg anomaly.
Right.
Dominal hand. For example, my dominant hand is left, and I don't have on the left side, but I have on the right side. Yeah. So maybe that's because of this. Yeah. I dominant hand is
quite likely. Yeah.
Thanks. So we don't have any questions for now. Not in box, not in Q&A. So thank you very much for the great talk. Very interesting and very useful. If it's okay, I'm recording this talk, and if it's okay, I can record. I can download on YouTube channel.
Okay.
And then send you the link, so you can send it maybe to your hand therapist or.
Sure. Yeah.
Okay.
Yeah, that'd be good. Yeah.
Okay, and I will email you about the next session.
Okay.
So we can arrange when and at what topic.
Yeah, so you can decide on quadriga, or you can decide on management of nerve transfers.
Okay.
Both. I can do both. Yeah.
Okay. Thank you very much for the great talk, for your time and your experience.
My pleasure. Great. Thank you so much as well. Okay. Have a nice day.
Have a nice day. Bye-bye.
Bye.
Отже, дякую, шановні колеги, що були з нами. І до зустрічі на наступних вебінарах. Нагадаю, в четвер 8:30 вебінар ФЕШ. В суботу подумаємо над тим, який вебінар будемо проводити. Можливо, знову ж таки попросимо Шріканта провести якийсь вебінар з реабілітації. Всім дякую. Перемога за нами, ми обов'язково переможемо. Слава Україні!